So, one death every 7 minutes. That is the worrying statistic in Nigeria, where on average a woman dies giving birth every 7 minutes. Nigeria has become the world's worst country to give birth, according to the United Nations. The most recent UN estimates for this country, compiled from 2023 figures, shows that 1 in 100 women die in labor. That is an estimated total of 75,000 women dying in childbirth a year, or one death every 7 minutes. Perhaps more worrying is the fact that a large number of the deaths from things like bleeding after childbirth are preventable. Other common causes of maternal deaths are obstructed labor, high blood pressure, and unsafe abortions. These have not been helped by Nigeria's poor health infrastructure, a shortage of medics, costly treatments that many cannot afford, cultural practices that can lead to some distracting medical professionals, and insecurity as well. So, what is the solution? Well, the government's come up with what's known as the Maternal and Neonatal Mortality Reduction Innovation Initiative, or MAMI. And for more on this, I'm joined now in the studio by the Executive Director and CEO of the National Primary Healthcare Development Agency, Dr. Muyi Aina. Thank you very much indeed for coming in.
Thank you, Charles. It's a pleasure to be here.
I have to say the statistics are absolutely shocking. Are you shocked by them, or were you aware of it all along?
Am I shocked? No. Am I saddened by the statistics? Yes. I think one thing we can all agree is that the outcomes for our maternal health, for our newborn health, are far worse than they should be. Whether it is we're the worst place in the world or not, I think it depends on who you ask, and there's different sources of data. Some have what is reported in the article that you cite, some even a little bit higher. But I think what we can all agree on is that there's a lot that needs to be done. And that's one thing that this government, led by President Tinubu, is taking head on.
Well, let me stop you there. I will come to that in a minute, but let's set the scene for us. Why is the situation so bad for maternal women in Nigeria? What's at the heart of the problem?
It's a number of factors. We have a very high fertility rate in Nigeria. If you don't get pregnant, you're unlikely to die from childbirth. The more pregnancies you have as a woman, once you start to get beyond 4 or 5 children, the risks get higher, not just because the body is getting weaker, but also the age. You know, you're getting more advanced in age. So that's one factor. The other factor is very health system related, which is the health system, particularly the primary healthcare system, but also the facilities that should provide the more comprehensive emergency obstetric care, they have been underfunded for many years. To provide quality, to have the health workers there, to have the equipment there, to have the infrastructure there, takes a lot of money. And I think historically, at least, there has been quite a bit of underfunding. So we've lost a lot of trust as well, you know, of the people. When people go to a health facility a few times and they don't meet the health workers there, or there's no power, or they don't have the commodities that they need, or they have to pay a huge amount of money out of pocket, they tend to trust less. So they look elsewhere to less qualified mechanisms to provide healthcare for them, and that increases the risks and worsens the outcomes as well.
So there aren't enough well-equipped healthcare centers, especially in the rural areas, that women can go to and get adequate care. What about professional staff? Because I understand that there are only about 121,000 midwives for a population of 220 million people. Obviously, they're not all giving birth, but I mean, you know, 121,000 in a large population like that, which means that less than half of all the births are actually overseen by a healthcare professional. And the WHO says that this country needs 700,000 more nurses and midwives to meet the recommended ratio. So a big shortage there, isn't there?
I think you're right. We have substantial shortages in the number of health workers, what we call skilled birth attendants. Those are doctors, nurses, midwives that are trained to be able to safely deliver a woman in a way that is safe for the mother and safe for the baby. And we do have a lot of gaps, largely because of out-migration. There's been historically a lot of pull factor from more Western countries who are able to pay more, who have aging populations, who have similar gaps that we do. But there have also been push factors, if we're going to be honest, in terms of the environment, the working environment, the infrastructure, and other conditions of service. But again, I'm hoping we will get to it, but each of these issues is now being tackled head-on by the government.
Well, let's get to it. What are you doing to bring the numbers down? I assume that's why the agency MAMI exists.
Yes, MAMI is an initiative, the Maternal and Newborn Mortality Reduction Innovation Initiative. And what it does is to bring to life a priority that the president has set for us, which is, you may be aware that about 2 years ago, towards the end of 2023, he had signed a compact with the president, with all of the states and all of the development partners, to say, look, there are certain priorities that we must attack head-on in this government. One of them is maternal mortality. The other one is sort of newborn child mortality. And associated with that is the quality of our health services, is the coverage of certain interventions. So what MAMI does, it's again, we're operating a sector-wide approach now. So everybody has a role in it. The National Primary Healthcare Development Agency is sort of leading in terms of the service delivery coordination at the state level. The states are the ones that run the facilities that own the health workers, so they have a critical role. But the Federal Ministry of Health, through the sector-wide approach, the SWAP office also is coordinating all of the advocacy, all of the engagement, and all of that. And what it really is it takes the problem of maternal and newborn mortality and says, what are the major causes and how do you tackle them? So the first thing is what I said, which is, one, you want to make sure that only women who want to get pregnant. So we're doing things to really make family planning and intentional pregnancies a lot more available to women. What we are finding is that, it used to be that demand was low for family planning, but we know now that there's a lot of unmet demand. So especially in rural areas, like you said, the little costs that it takes, the wherewithal, is not universally available to everybody. So we have interventions of the federal government backed by policy and resources where we are making family planning commodities and services available for women. When you do get pregnant also, you do need to be taken care of through the pregnancy. There are issues of nutrition, there are issues around treatment of fevers, making sure your baby is fine. And when there is a signal of a risk, is making sure that you get seen and cared for by the right level of care. So what MAMI really is taking a roster of pregnant women in priority local governments. We started with an analysis that said, look, if you can't go everywhere, you have to start somewhere. And we identified 172 local government areas across 33 states that account for 55% of maternal deaths. So if you were able to reduce the incidences of deaths in these areas, you're going to make a big dent anyway.
But I mean, has it properly taken off? Because I was reading somewhere that it's in the pilot stage.
Yes, you look, it's in the pilot is now being concluded. We're now expanding, to 5 or 6 states because we needed to figure out how to do this. And the first thing we did is to even get a roster, a line list of pregnant women. First, you need to know who's pregnant and where, and then work on a case management basis with each woman to make sure that as they walk through the journey of pregnancy, we're right there with them, and childbirth and the immediate postpartum period, that the government, the health system, is right there with them, and whatever they need, when they need to get an ultrasound scan to figure out what, if you know, the lie of the baby, they get it. When they need to get skilled birth attendants at the time of delivery, they get it. But what's more important, for those who are at risk or in fact develop complications, they are now being linked as well to secondary facilities with specialist care. And you may also be aware that as part of MAMI, the president has approved free cesarean sections for women.
Yes, I read that. I read that
for
somewhere,
women
yes,
who, in fact, receive services in high quality facilities that we know. And I can tell you that as at when I was last aware, over 4,000 women. So these are real people. So this is not, that's few compared to the several millions that have a baby every year. But I personally know, you know, in the past, a couple of women that passed away because they just couldn't afford the fees for this. Hopefully, with this intervention now, a woman never has to die again because she cannot pay for cesarean section. So every woman now who needs emergency cesarean section, you know, is covered on this program.
But I mean, you need to raise awareness though, don't you? Because I mean, you pointed out that a lot of people are very skeptical,
Yes.
and they, you know, you need to kind of educate them, don't you?
It's funny that you say that, because on my way here, actually, I was just chatting with somebody who's a friend, and I was telling her some of these things, and she was very skeptical, and understandably so. But I think we are doing what we can to raise awareness, but that's where partnership with you all in the media also matters, and that's the importance of conversations like this to also help put the word out there.
Right.
You know, there's also a sequencing of things. What you don't want to do is have your demand overshadow your supply. I told you that historically there have been many gaps, and you know that in the system. So we're building out at the primary health care center level, for example. We had less than 1/5 of our basic healthcare provision fund facilities that met the bar of level 2 that could safely deliver women. In the last year, we have added another 1,100 real facilities. The list is right there on our website and can be verified. But you see, that's not still fast enough to hit everybody at all once. So that's why we're prioritizing. We're putting the word out there, but we're also being deliberate in making sure that if people do show up, we are able to meet them there. So you don't worsen the cycle of distrust in the system.
Well, I mean, you talk about distrust because there is a considerable amount of that, isn't there? I mean, many people say they don't. I mean, you mentioned that, you know, your friend when you were coming here and so on. But many people say they simply don't trust the hospitals that are there because there are just too many stories of negligence, especially in public hospitals.
Again, I think there's some validity to that. But you see, what do you do when you have a problem? You try to tackle it. And that's what the government is trying to do. We're not denying the fact that people in the past have had reasons to feel like
in the past and the present.
Well, in some regards, but hopefully it's getting better. And if you do speak to people as well, we also get some feedback. I think there is a sense now that at least there's some movement. We still have a long way to go. There are 8,800 wards in Nigeria. There's 230 million Nigerians. 1,100 additional primary health centers will not do it. But we have a target of getting to 17,600 over the next few years. Now we have to move with resources. But you see, it's even easy. If you give me money, I can fix facilities, I can buy equipment, but it takes time to produce the health workers. It takes time for them to be trained.
Indeed.
One of the things that the president did is to commission us to retrain all of the frontline health workers, 120,000 of them. You said 121,000. That's the right number about. And we're right now almost at 67,000 or thereabouts that have been retrained in integrated primary health care services, but specifically also looking at, safe maternal care services and newborn care services. One of the other things is that you can have the basic services, you can have the more comprehensive emergency services, but you have to be able to get from one point to the other. So at the same time that we're doing this, the Federal Ministry of Health has also rolled out a national emergency medical transportation system, which gives vouchers in many states now to pregnant women who need to move from their homes to a health facility or back.
Right.
So we think that...
But no provision for ambulances.
No, ambulances.
Because one thing I notice in this country is that you never hear sirens from ambulances.
So
you hear sirens following big fat men around the place, but you never hear sirens.
So the emergency transport services are via ambulances. The question is, does government necessarily operate the ambulances, or do you take a mixed approach as is done elsewhere, where you have private providers and the government just pays through vouchers?
Well, we're not seeing those ambulances.
It's growing out.
If you give a pregnant woman a voucher and she gets into some public transport, that's not the best way to get to the hospital when you're in that state, is it?
That's in fact correct. But you see, you have to start somewhere. Again, I'm aware that there are several states now that have rolled out their emergency ambulance services. Some of those vehicles directly procured by the federal government, many of them procured by the state government. Is it everywhere? Can you see it everywhere? No. And it will take take some time to get there. But I do think that there is progress. And what I would like is to encourage people to at least see the progress and use it. You know, I think to the extent that you have ambulances even in the rural areas that we're targeting first, to the extent that you have these facilities that are being revitalized, if we don't somehow overcome the distrust and have people use them, it's no point.
Indeed.
It's going to just go to waste. Yes.
Right. Well, what about your budget? I mean, because you mentioned the key issue here being finance, obviously, because you need the finance to buy all the equipment, train all the people, build the facilities. The federal government, from what I understand, currently spends about 5% of its budget on health, which is well short of the 15% that Nigeria committed to in a treaty it signed with the African Union in 2001, I believe.
I think you're correct. The target that was signed in 2001 that was agreed to is about 15% of the budget should go to health. And again, that's not what has happened in Nigeria historically. But guess why we're excited is that this president, that I'm very proud to be associated with, increased the health sector budget, you know, almost to a doubly fold between 2023
but it's
and
5%. And the target is 15%.
Well,
so it's well short.
But you're moving in a direction. You're moving in a direction. You know, you have to also understand that we work within a context. It's not like the country is right now aflush with money. So the fact that you can increase from 2023 to 2024 and also increase from 2024 to 2025 very substantially, and that trickles down. My agency, for example, the budget last year was 3 times the budget we've ever had, you know, in any year. When you look at the budget in 2025 as well, there's a similar trajectory. So I think
so did you commit a significant amount of that budget to? What was your priority given this increase in your spending?
I told you that there's been about 1,100 facilities that were revitalized over the last year.
So building new facilities,
training frontline health workers, providing commodities that are needed. Many of them, you know, postpartum hemorrhage kits to help women so that they don't bleed to death. The medicines that they need, oxytocin, the antibiotics that they need, the anti-malarials that they need in pregnancy, the family planning commodities that they need so that they can you know, get them when they need them. In a way that, you know, you can't continually as a federal government fund everybody, but at least we're giving seed stock and certain systems for the states too. But also in addition to that, I have to tell you, the federal government mobilized $1 billion through a project to the World Bank that will support primary health care, a big part of it, which is also maternal and child health services. And the way that would work is incentivizing states and local governments to also put their own resources. So when you hire a skilled birth attendant, you get reimbursed some of that money. When you provide certain commodities, so we have it's called disbursement linked indicators, DLIs. If you have a certain percentage of your health facilities through some independent verification process have adequate stocks of tracer commodities, you get reimbursed for that. If the facilities meet the standards that we have defined as level 2 quality, which is they've got decent infrastructure, that a woman feels comfortable, to come and have a baby in a dignified way. You've got the minimum number of skilled birth attendants on duty with accommodation so that they can sleep overnight. You've got reliable power, and in many instances that's solar powering, so that you can be powered 24 hours. You've got the basic equipment and you've got the commodities. You also get reimbursed. So there's many ways that we are coming at the problem as a government, and I think Nigerians will start to see very soon. By the way, one of the things that we're also doing, I did hint to you in the beginning that there were many different measures depending on who you asked, is also to be a bit more disciplined with the way we measure our approaches, to know what's working and what's not working. And if it's not working as well as we think it will, we modify or change course based on what we're learning. We are doing something called the mini DHS. It's not the government that's going to do it, but the government is facilitating it basically. The next one will be next year, which will be, we're not going to wait 4 or 5 years to measure the outcome of what we're doing. We want to measure very closely so that whatever is working, we build on it, and whatever is not working, we sort of dial it back and reprogram our efforts.
Well, thank you very much for coming in to talk to us about these things, and also what you're doing, and come back and talk to us again.
Absolutely, Charles.
As the whole sort of programs progress.
Absolutely.
Dr. Muyi Aina is the Executive Director and CEO of the National Primary Healthcare Development Agency. Thank you very much indeed.
Thank you, Charles.